Thank you. Once again, I would like to take a moment to thank Professor Siebenrock for the invitation and making me part of this amazing faculty. It's an honor to be here. I'm going to talk about when we should move on towards arthroplasty. As probably you would all agree, total hip arthroplasty is probably one of the most successful surgical procedures ever designed. And if you read this article, you probably would never do any hip resurfacing, hip preserving operations because some enthusiasts think it's probably one of the best surgical procedures. It wasn't like that when we first started doing total hip replacements, and the founder of total hip arthroplasty initially said this was an operation only for the elderly, and it should not be performed in young patients with dysplasia, and by young he meant 65 years of age. I remember when my father was also an orthopedic surgeon, and he was probably the first person to perform a total hip arthroplasty in my country, Turkey, and I remember him talking to his patients and saying that he's going to give them an operation that's going to last 5 years. Fortunately, over the years, by the improvements in technology and surgical techniques, we can now talk about a much longer survivorship using total hip arthroplasty. We've been talking about this in the last 2 days. We know that subtle anatomic changes and some small problems can lead on to early osteoarthritis, and we all know this, and we discussed this quite a lot yesterday. And even the slightest amount of dysplasia can cause early disabling arthritis in very young age. And nowadays, our patients are demanding much more from us, and they will not accept a surgical procedure that will probably, when you introduce them to that concept and say that, well, I'm going to do this operation, perhaps you're going to get better within X number of months, and then it's probably going to last you X amount of time. People are starting now to say, I want something that's going to last longer and for my whole life, and I don't want any other operations. But however, despite that, with the knowledge we have now, we try to do hip preserving operations, just like this Pemberton osteotomy, Salter's osteotomy, and as we discussed yesterday, different periacetabular osteotomies to improve the anatomic, correct anatomic problems and improve the hip mechanics so it will last for a long time. As Professor Siebenrock has shown us, these surgical procedures, especially the periacetabular osteotomy of Bern, can last quite a long time. But when they took a more critical view of the patients they did operate, and looking back on their experience, they demonstrated us that if, for a good result, the patient had to have a good hip joint, and osteoarthritis shouldn't have been, the patient shouldn't have osteoarthritis. And the patient had, after the surgery, should have at least a good joint congruity to achieve that long-term successful result. Again, we now know that impingement surgery works quite well too, but again, for it to last a very long time and prevent arthritis, we need to achieve a good surgical correction. And fortunately, we now have some additional other surgical procedures to improve the joint congruity, improve the mechanics, and we have many tools now, but again, all of these unfortunately have some amount of limitations. We are now starting to get long-term results of hip arthroscopy, and again, when you look at these papers critically, for these to be successful, the patient shouldn't be in an advanced age. You should be able to correct the associated other mechanical and anatomic problems, and you should be able to correct the problem that is causing the impingement to achieve a good result. However, over time, now we have, there's been a paradigm shift in the last 10, 15 years with the improvement of the bearing couples. We have now much better plastics and stronger ceramics, and we have developed surgical techniques to improve our surgical approach. We are now able to use larger head size and achieve a pretty good result even in young patients. When you look at the Swedish Arthroplasty Registry report from 2014, even in young patients, which they defined as less than 50 years of age, you can achieve good long-term survivorship. And even younger patients can have a significant improvement with a total hip arthroplasty, and as the time is passing, we're getting more and better results with it. So what's the problem? Why are we hesitating to make the decision of implanting a total hip replacement in young patients? The number of revisions are increasing as well as we're doing more and more of these procedures. And as we'll probably discuss later on today, the other problem is infection. We solved many issues relating the wear of the couplings, the taper corrosion issues, but there's one problem we haven't solved, and that's the infection. And if a young patient gets infected, the second operation that patient's going to receive is going to last even less than the previous one and be more disabling than the previous one. So when we look at what we have today, joint preservation versus using new technologies of total hip arthroplasty, we still are in a dilemma. For a hip preservation procedure to work well, we must understand that we need a reasonable amount of congruity and be able to correct the impingement problem we can see in these patients. And when we look at the new studies, the patient should have at least more than 2 millimeters of cartilage, and the labrum should be we should be able to reconstruct or repair the labrum to achieve a good result, and the patient should not have osteoarthritis for the hip preservation techniques to work. And one point I must make is that if we're going to do a hip preservation technique, we must make sure that we do it right. This was a patient that came to me. He had a hip arthroscopy 6 months ago, and as you see here, he's now in severe pain because a 45-year-old man, severe pain because he has his arthritis increased. And when we did a total hip replacement in him, we saw that they took out the labrum during arthroscopy, and this is the cam resection they did. You see the remaining cam is still there. All they did was take out only 1 square centimeter of bone, and of course, the patient rapidly deteriorated his joint. We must keep in mind that hip preservation procedures aren't complication-free. This is one of my patients. We did a perfect periostebular osteotomy, but when he woke up, he had sciatic nerve loss, and so we took him back to the operating room, explored the sciatic nerve, and then when we woke him up from that, we saw it was okay. The leg was not perfusing, so we went back in and explored his arteries, and he had a huge thrombosis in the iliac artery. Later on, he got infected, but now he's doing fine. This was a patient that had a hip arthroscopy. She felt so well. She was over 40 years of age. She went back to her sports routine, fractured her femoral neck, and had a total hip replacement 4 weeks after her hip arthroscopy. This was a young lady, 26 years of age. We did a perfect periacetabular osteotomy. Postoperatively, 12th day, she expired of pulmonary embolism despite venous thromboembolism prophylaxis. So I would like to say that in patients less than 40 years of age, I think we should do our best to correct the problem in the hip joint. And after 40 years of age, if arthritis is started, then probably total hip arthroplasty is going to be a better choice, and we should stop the hip-preserving procedures at that time. If we're going to do a arthroplasty, we must make sure we do it well with the best implants available to us. This was one patient that had a total hip replacement when she was 25 years of age, ankylosing spondylitis. After 20 years and about 25 different surgical procedures, 6 hip dislocations, 1 infection, I had to do this hip replacement to her to get her up and mobilized when she was 60 years of age. So my final word is, after age 40, when there's arthritic changes present and less than 2 millimeters of cartilage remaining, probably total hip arthroplasty is a better choice. Thank you for your attention.